Hello, everyone. Looks like we still have a couple of folks rolling in from the waiting room. All right, I think we have almost everyone now. We'll give everyone a second. All right, well, good afternoon. Thank you so much for joining us for today's webinar presented by Kentucky Psychological Foundation and Mental Health America of Kentucky. First, I'd just like to share a couple of housekeeping items and also tell you a bit about our organizations. Kentucky Psychological Foundation focuses on bringing trusted mental health information to the public, and Mental Health America of Kentucky aims to increase the accessibility and quality of mental health and substance use services in the state. Programs presented by Mental Health America of Kentucky are also supported through a SAMHSA grant awarded to the Kentucky Department of Behavioral Health, Developmental, and Intellectual Disabilities. And this webinar is also supported by a grant given to us from the Fayette Bar Association. KPF and MHAKY work together to bring you this webinar series, focus on bringing experts together to provide education and awareness. And we will drop the links to our organization websites in the chat. We'd also love to hear more about what mental health topics you want to know about, and we are listening. So if you have ideas for topics, you can share those in the chat or contact us separately. I will check the chat for questions throughout the webinar, and we'll also save some time at the end for question and answer as well. Today's webinar will focus on inpatient psychiatric treatment in Kentucky, including both voluntary and involuntary care. We'll discuss the 202A process, patient and family rights, and the typical course of treatment, as well as some other items. I am very pleased to introduce our panelists today, Dr. Lindsay Jasinski and Judge John Tackett. Dr. Lindsay Jasinski is a licensed clinical psychologist and the Chief Administrative Officer of Eastern State Hospital, which is managed by UK Healthcare and UK's Empath unit. She has worked for UK Healthcare in various clinical and leadership roles for 15 years, primarily serving individuals in inpatient settings. She holds a PhD in clinical psychology from the University of Kentucky, as well as a master's in health administration from the University of Kentucky. Judge John Lindsay Tackett was born and raised in Lexington, Kentucky. He attended and graduated from the University of Chicago and later the University of Kentucky College of Law. After years of experience working for the Lexington Fair Housing Council and multiple law firms and running his own general law practice, Judge Tackett was elected to the bench in 2018. As a district judge, Judge Tackett serves on the statewide District Judges Educational Committee, chairs the Bob Heaton Award Subcommittee, and is a ranking member of the Kentucky Judicial Commission on Mental Health. Judge Tackett also presides over the nationally recognized Fayette Mental Health Treatment Court. Thank you so much for joining us today, Judge Tackett and Dr. Jasinski. So first, I'd love to just get started talking a little bit about inpatient psychiatric treatment in Kentucky. Dr. Jasinski, to start, can you briefly describe the current landscape of inpatient psychiatric treatment in our state?
Yeah, absolutely. Thanks, Hannah, for the introduction, and I'm glad to be here today. Happy to always speak with Judge Tackett. We have lots of overlapping work that we do, and it's always a privilege to get to speak with him as well. So glad to be here. I can kind of give a high-level overview of what inpatient care looks like in Kentucky. I can tell you at a very high level, we are fortunate in Kentucky. Many states across the country have extensive wait lists for inpatient hospitalization because of capacity shortages. In fact, I had found a statistic that about 40 states have wait lists for inpatient care. We are fortunate in Kentucky to not have that. We do have beds available both in sort of the public hospital sector, in private hospitals. We also have state psychiatric hospitals, as well as forensic beds at our KCPC facility. The state psychiatric hospitals are Eastern State Hospital in Lexington, Central State in Louisville, Western State in Hopkinsville, and then ARH also has several units as well. And then there's a smattering of other inpatient units across the Commonwealth. Many of those are about 20 beds each, so they're a little bit smaller. Um, we, as a country, they actually recommend that you have 50 inpatient beds per 100,000 residents. And more than 60% of the US population actually lives in a psychiatric inpatient bed shortage area. So they do not meet that ratio. That is particularly true. The wait lists tend to be longest for forensic inpatient care, but can be anywhere. And when you have a lack of inpatient beds, you see increased ED boarding. You see jails tending to serve this population more frequently. And you also see, the possibility for shorter length of stay or premature just discharge to the community. In Kentucky, we do have inpatient care that is available at any point in time. We have beds available for age ranges all the way down to age 5 through adults. And that can include, like Hannah mentioned, voluntary treatment. So someone who believes that they need inpatient care and they believe that that's the level of care that's right for them. And involuntary treatment. And we'll spend some time talking today about, especially for adults, the 202A process, which is involuntary treatment. In terms of the landscape, you often hear folks going to one of those smaller community hospital or other inpatient units. And those hospital units can serve voluntary patients, but they can also serve involuntary patients, but usually only up until 72 hours or 3 days, business days. After that point in time, that individual, if they need further involuntary care, would go to a 202A designated facility, which is our state hospitals. Those are defined, the hospital that you go to is defined by a catchment area. So oftentimes people believe, well, I want to go to Central State or I want to go to Eastern State. Those are actually defined by the area that you live in. So, for example, Eastern State serves 50 counties in Kentucky. Um, those hospitals then also work very collaboratively with their local community mental health centers. So at Eastern State, we actually serve 5 community mental health centers. And the reason for that is to integrate that care from hospitalization to the community to make sure they have that outpatient care, or it might be ACT team, assertive community treatment, or another level of care that they need moving back into the community. Um, so that's kind of a high level overview. The process looks a little bit different for adolescents because a guardian is able to consent to inpatient treatment for an adolescent, whereas an adult patient, if somebody is a guardian, either a state guardian or a family guardian, we cannot admit that person under guardian consent only. That would have to be evaluated under those criteria for involuntary treatment. Judge Tackett, I don't know if you had anything else to add there, Hannah, if that answered that question for you.
Absolutely. Thank you so much. It's great to hear about all of the treatment that is available to Kentuckians and how everyone works together. Can you tell us a little bit about some common misconceptions that you encounter about inpatient psychiatric hospitalization?
Absolutely. So I think one of the biggest misconceptions is that it has to be involuntary. Even at Eastern State in the state hospital, we serve a number of voluntary patients. And so folks can come to the hospital and seek care and be able to access care that way in any hospital. A large portion of folks do require involuntary care if their illness has gotten to a point where they may not have full awareness into the risk to themselves or others. But we really try to use involuntary treatment as a last resort. We want to engage that person. We want to collaborate as a treatment provider in the hospital and say, let's work together to create a plan. So we really do try to use involuntary treatment as a last resort. And that holds true for forced treatment as well. There tend to be a lot of misconceptions around everybody that comes into the hospital, for example, might be required to take medications, which isn't true at all. In fact, patients have lots of rights that we will talk about when they're in the hospital setting. Forced treatment actually is an extensive process. Judge Tackett knows this. It takes several weeks of different reviews to engage in actual forced treatment. And so what that means is that the patient and other physicians and the judicial system weigh in on whether that is truly the only way to get somebody care. It really is a last resort and something we try to use very, very infrequently. Um, Oftentimes people are scared of a hospital because they say I'm going to be strapped down to a bed or I may not have a lot of choice in my care. And again, restraint rates, seclusion rates, any type of restrictive intervention that we might need to do are very, very rare. So, some data from Eastern State Hospital, for example, less than 6 out of 100 patients that come into us require any kind of hands-on, and that could include having to just put someone in a very brief 2-minute hold to give medications if they're agitated and not able to maintain their own safety. But we only use those medications in those crisis kind of situations and for that individual's protection. Um, One thing I often hear, and Judge Tackett knows this very well, is that when somebody comes into the hospital under 202A, there is a 60-day petition that might occur. What I often hear from family members is, will you discharge them after 30 days? And the 202A statute is actually very clear that once that person no longer meets criteria, the physician is to discharge them. So that 60-day petition that you might hear about is up to 60 days. It is not a guaranteed 60-day hospitalization. Many times folks are able to stabilize and return to the community far before 60 days. But we often get questions from family members saying, well, they had a 60-day petition, but you didn't keep them the full 60 days. And the statute is actually written that the doctor that is seeing them has a lot of decision making at that point to say, do they continue to meet criteria? Because we want that person to be able to access the community as soon as they're safe to do so. Um, I, I also hear a lot of concerns about the environment in terms of, does it feel like a jail? Does it feel really sterile? Things like that. I don't know if any of you have seen the new, some of you have, the new Eastern State Hospital, and it is much like any other hospital. There's rooms, there's patient care areas, there's exam rooms that you might see a doctor in. They're like any other medical exam room. There's an outside area. There's actually lots of natural light. So inpatient hospitalization often has a connotation because of what we see in the media as a scary place. The reality is, it is a place that's designed to serve anybody. We serve professionals in the community. We serve anyone that needs help. And it's designed to be able to provide that care.
Wonderful. Thank you so much for that comprehensive overview. I know you just talked about who the system is designed to serve and touched on where families can sometimes feel confused or overwhelmed. Can you expand on that a bit?
Yeah, absolutely. Anytime you may have a loved one that needs inpatient care, potentially, it's scary. It's overwhelming, it's difficult. And so the places, and we'll continue to talk about this today, but the places I hear concern from families, who do I reach out to? Who do I talk to? How do I get this person help? And then what am I able to provide as far as information to those treatment providers? There's certainly some limitations around what the treatment providers can say to the family members. That those are governed by privacy laws for that patient, and we do have to have a release of information. But family members can always, under any circumstance, provide information to those treatment providers. And so navigating the system is complex. We'll talk a little bit about how to do that and how to get help when your loved one needs help. And I think the good news is our system is continuing to evolve, and so help is more readily accessible. But there's still lots of questions I think that family members have, and it's just a difficult time when you have a loved one or yourself that needs inpatient treatment.
Absolutely. Thank you so much for sharing about inpatient psychiatric hospitalization. Judge Tackett, Dr. Jasinski touched on the 202A process. Can you walk us through that process step by step from petition to potential hospitalization?
Sure. And I'll do my best here. I knows Dr. Sussman's on here, so if he's maybe more of an authority on this than I am. So if I misspeak, Dr. Sussman, you just jump right in there and correct me. But there's multiple pathways to involuntary commitment through 202A, and Dr. Jasinski has already hit upon it doesn't necessarily need to be involuntary. I mean, they will take folks who need voluntary assistance, and that comes up sometimes in rural counties where someone wants to attend and go to the hospital, but they just simply lack transportation to be admitted. So they start the 202A process. So that's something that we don't see in Fayette County, but I've heard tell. And let me, before I get far, and this is something that Dr. Jasinski and myself are both on the Kentucky Judicial Commission on Mental Health, and they just published. This is free for you all to pick up online. They did town halls in I think 14 different locations, just talking to stakeholders about the 202A process, and they published this serving citizens through the 202A process document. So you can find that online, and it's going to answer a lot of questions that we probably won't have time to address today as to some of the weaknesses in the system, some places where there's issues that we need to address. So I just want to make sure that everybody knows that's out there. It's a fantastic resource that the commission's put together. So, but where we see it is warrantless arrest. So a peace officer would have reasonable grounds to believe that an individual is mentally ill, presents a danger. And of course, the criteria that we're talking about is poses a threat or danger to self or others, could reasonably benefit from hospitalization. And hospitalization, as Dr. Jasinski has addressed with the 60 days, is the least restrictive form of treatment. So, and then the peace officer would, in a warrantless arrest situation, transport the individual to a hospital or a behavioral health facility designated by the cabinet to be evaluated by a mental health evaluator. And then the peace officer would provide the written documentation that describes the behavior to that person that caused the peace officer to take them into custody. And then at that time, they would be evaluated to see if they meet criteria. And if they met criteria, they'd be admitted. If they're not, they'd be released. Where I see it most is hospitalization by court order. And so that's where typically it's usually folks who are already in the hospital or being cared for by a physician, and their symptomology has gotten to the point where they need they no longer can be provided with the services at that hospital. They need a higher level of care, maybe in an emergency room setting. The doctor is saying to us, this person meets criteria. We need to have them admitted to Eastern State for us in Lexington. Similarly, the court gets a petition, and it can be also from, usually it'll be a family member or friend too, or possibly a social worker or members. Dr. Jasinski has already discussed the ACT team. We occasionally see that, or a housing provider that says this person's in crisis. Court, would you all look at this petition and see if they meet criteria? So that being the case, we will issue an order if we think that the petition meets the criteria to have that person involuntarily hospitalized, but for no more than 72 hours. And then after the person is ordered to be admitted, they must be transported from the person's home county by the sheriff or other peace officer as ordered by the court. And the sheriff or other officer may, upon agreement, authorize another party to do the transfer. And we'll talk about that probably some more. That's a huge barrier is transportation. That's where we run into a lot of problems. And so after the 72 hours, there's an assessment made whether they need to be released or if they do require it. And then it'll go into a further process whereby we'll be looking for a filing for a 60 or a 360-day commitment period. And then the 72-hour emergency admission, and that's done by authorized staff physician at a hospital. So under a doctor's order, they may order the admission of any person who is present at the hospital. And the authorized staff physician may order the person to be involuntarily hospitalized. And then within 24 hours of admission, the staff physician may certify in the record why he believes the person should be involuntarily hospitalized. And then after the 72 hours is completed, the other three options, whether the patient needs further inpatient treatment and is willing to sign a voluntary admission, if they do not require further inpatient treatment, they're released, or if they need further treatment, and again, they will not voluntarily admit it, then the hospital will file a petition for 60 days. And then that process, we have to have a preliminary hearing within 6 days to determine, at the outset, whether or not this person, if there truly is a need for further involuntary hospitalization. And the case get in after that preliminary hearing, or it could proceed to either, a final hearing where the 60 or 360-day commitment order is entered. So that's just a hopefully Dr. Sussman thinks I did a good job. That's where we're at.
Thank you so much, Judge Tackett. And wow, I mean, these sound like pretty lengthy processes. And for folks who are joining on today's webinar and may not be familiar with these processes, it may sound a little confusing. I know that you had mentioned transportation as a barrier. Can you touch on some other common points of confusion or delay in the 202A process?
Uh, sure. Transportation is a significant barrier because uh, especially in your rural counties, the sheriff's office is usually the one that will make that determination. And then especially, talking about overnight, that seems to be a lot of times when these episodes occur. So when you get the judge, they'll be conflicted as to should I even sign this order, knowing that I only have maybe one deputy. So it's a safety concern for, do I choose to send this person who is, potentially at risk to himself or others to involuntary commitment, and then occupy this deputy's time for 6 to 8 hours, leaving this community exposed to whatever they have to do as law enforcement. So that's certainly an issue that a lot of our rural counties face. And then we've had issues in Fayette County just with services from the sheriff's department not being able to transport to overnight, and we've had to work those out. So that those transportation is a major issue. Um, I think for us, I don't see it quite often. There might be some confusion on behalf of parties as to what the involuntary commitment statute really suggests, like especially concerned family members who maybe folks are just not taking their medications, or they're, under the influence, or they just know things aren't going well for this individual, their loved one, but they don't meet that high criteria of being a danger to self or others. And there's a lot of confusion. So I will have to, a lot of times I choose to individually meet with, the petitioner in that case and just try to explain here's the high criteria that you need to meet. And a lot of times, sometimes they haven't filled out the petition adequately. They haven't discussed their prior psychiatric record. They do have a diagnosis, but a lot of times they don't, So and then just having to explain, we can't just do this willy-nilly. There is a high bar for us to, admit someone against their will to a psychiatric hospital. So I hope that helps.
Definitely. Thank you so much. And we actually have a question in the chat as a follow-up
Sure.
um, about who holds the patient and where while they wait on transportation, the CMHC, local jail, ER, etc.
So my understanding, and you all can correct me if I'm mistaken, but when I issue the order, they are to be detained until they are assessed. And so that means that they are being held by the hospital until the sheriff takes them into custody. It's basically they are being detained against their will until they are screened. And then upon the screening, it's determined whether or not they will be admitted. And then once they're admitted, they are of course held by the hospital until they either do or do not make criteria, or they don't make criteria and they're released, or they do and they it goes through the legal process. So that's how it works. And then if they're on the street, and that's when we're talking about our sheriff's department, and our sheriff has we try to give them as much information as possible, especially about the safety of the deputies. Is this person armed or potentially dangerous, or and try to give as much explanation in that regard, because they are meeting someone in just like any other arrest for a warrant in criminal activity, what have you, contempt. They're being taken into custody and they're no longer free to walk around and exercise their rights. So.
Thank you so much for answering. We have another question for you in the chat.
Mhm.
Um, uh, as a provider who processes 202A inside Jefferson County at University of Louisville ER. Oh, it's not a question, just a commendation. I appreciate the thoughtfulness you put into reviewing and improving
Oh
petition.
yeah, of course.
Um,
Always.
So now that we've talked about 202A, I'd love to move on, talk a little bit about Tim's Law and Casey's Law.
Mhm.
Can you tell us a bit about Tim's Law, how it differs from 202A, and when it's most appropriately used?
Sure. So Tim's Law is establishes a court-ordered assisted outpatient treatment program for individuals with serious mental illness. And the aim of Tim's Law is to break sort of the cycle of hospitalization, incarceration, homelessness. So what the typical candidate for Tim's Law is, when we talk about involuntary hospitalization, you're talking about someone who's in immediate crisis. A lot of times I think of it as typically falling into the bucket of suicidal or homicidal ideation. Those are the major red flags. It could be less than that, but that's where, they need immediate stabilization. Tim's Law more or less is this the person has probably, been released from the hospital. It's just they have a history of not being medication compliant. Or they have anosognosia, they have lack of insight into their illness. And chances are, if once they're stabilized, that they are going to, because of their lack of insight into their diagnosis, not take medications and then come back to the hospital at some point in time. They're not, so it's going to get elevated where they, are not compliant with their plan, the discharge plan. So what Tim's Law does is and I've covered Tim's Law. That's Judge Gunther here. My specialty really is our criminal mental health court, which is completely different. It's a diversion court. But Tim's Law acts in the same way as our diversion court in this way is that we have a team, a wonderful interdisciplinary team built of our community mental health providers. ACT team usually is involved through New Vista with us, and then our county attorney and our public defender, and other, community partners, and of course Eastern State too. And so we're trying to get the person on plan. We use what we term as the black robe effect. It doesn't have contempt powers, but lots of times it's surprising how many people want to please the judge. They're very happy about making, me and Judge Gunther happy. And so, what makes us happy is, are you taking your medications? Are you going to therapy? And it's also valuable in this aspect because it's routine court appearances. So we get to, eyes on these folks out in community. And if we detect, we think that there's some, increased symptomology or they're, showing signs of distress, even from our laypersons, because it's usually us, there might be a psychologist there from New Vista that is there with like a trained eye, but we can, say, guys, this is going in the wrong direction. Can we, get him back into a medication prescriber and look at, like levels of medications? I mean, he's taking the medications, it's maybe not working, what have you. So we can, basically as a team make suggestions. But hopefully, that they are successful and they're compliant, and it's a lot of hands-on and conversation, and it's court that, you know, um, if you think about district court where I am, you get a 150, docket criminal trial or criminal, traffic docket, and you're just moving as quick as possible, through these people and getting them, out the door. So here it's a conversation, and you're getting to know these folks and you're spending time with them. So it's a big difference. So that's a little bit of an overview of Tim's Law, but it's targeted at individuals with serious mental illness who have a history of repeated hospitalizations twice in the last 48 months and a history of dangerous behavior resulting from noncompliance. And basically the goal is, and I should have said this at the very beginning, the goal is to keep them out of the hospital. That's the goal of Tim's Law. I mean, if we're doing our job, they are not going back to the hospital. And that's, their goal too, of course, to stay out of the hospital, so.
Thank you for that really helpful overview. You touched a little bit on medication management, et cetera. Can you expand a bit on what role outpatient court-ordered treatment plays in preventing those repeated hospitalizations?
Yeah, a little bit, like I said already, just, making sure that we're in contact with them, making sure that they develop a plan, making sure they're getting the right medications, making sure that they're showing documentation that they're in recovery groups or that they've met with their medication prescriber and met with their therapist, and whatever their plan is, that they're checking the boxes. And I don't like to say checking the boxes because I don't like to think of that as far as recovery. I want to see more of sort of a plan that works without, just do this, do this, do this, and you're good. It's really, more than that. But that's the way I guess I framed it. So
Great, thank you. Moving on to Casey's Law, can you tell us a bit about Casey's Law, how
yeah.
it fits into Kentucky's behavioral health system, and what populations it primarily serves?
Yes. So Casey's law is different in that it doesn't, of course, from where I sit with our mental health court, our diversion court, 80% of our folks have co-occurring substance use disorder that have serious mental. So we this is not just one thing. We know that substance use disorder plays in to mental illness quite often. But Casey's Law is primarily, targeted at substance use disorder. So it allows parents, relatives, or friends to petition the court for involuntary court-ordered addiction treatment for a loved one who does not recognize their need for help, and it mandates treatment for up to 360 days if the person poses an imminent threat to themselves or others. So its purpose is to provide a legal way to compel treatment for substance use by bypassing the need for voluntary consent. And that it's, you petition the court as a friend or a loved one of someone with substance use issues to get them in front of the court. The main difference between Casey's Law, or one of the main differences between Casey's Law and Tim's Law, is that Tim's Law, if you're not abiding by your wellness plan, if you're not compliant with your medications, we're not going to put you in jail. Okay, in Tim's Law, there's no contempt power of the court. The main thing that happens is you go back to the hospital. You could be, if you meet criteria, you'll be petitioned back for an involuntary commitment. The difference in Casey's Law is, yes, you can go to jail for contempt if you're not abiding by the treatment plan. So we see people come in all the time. They may not even be charged with a crime, but they're not complying with substance use treatment, and so they're being held. And a lot of times they're, being held until they find a bed for involuntary or inpatient treatment, I should say. That's a big difference. Another big thing you need to know about Case's Law is it's the petitioner is, unfortunately, um, the petitioner has to pay the cost. So if you do get into a treatment program, the petitioner is responsible for paying the cost, hopefully through insurance, but if not, they're on the hook. Unlike, other courts, such as my court, you're in criminal trouble, we're gonna find some way to get it paid. So that's how that works. So the petitioner would have to pay.
Thank you. That is very informative and very interesting. I'd love to hear from you both, and we'll start with Dr. Jasinski. Judge Tackett will give you a break from talking for a second. Can you tell us a bit about the rights that patients have during inpatient psychiatric treatment and what role they play, regardless of admission status?
Yeah, absolutely. So patients actually have a lot of rights. Even though involuntary treatment by its nature sort of seems like you are removing rights from patients, they actually have a number of rights in the hospital setting. The first of those, and I think probably the most important and fundamental, is that they're to be treated with dignity and respect. And these are defined by statute. But they're also just good moral compasses for us in the inpatient world to abide by. And, being treated with dignity and respect means that you are free from abuse and neglect. Your basic needs are met. You are in a safe and clean environment. You're provided the care that is evidence-based and suitable for your needs, meaning you are provided with substance use treatment. If that is a co-occurring condition, you are provided with medication and therapies and recreational activities and things like that to meet those needs and ensure that that quality of care is safe and abides by the evidence and the literature of what we know is effective treatment. Another core right along those same lines is that you have a right to be in the least restrictive environment, and that includes being free from seclusion and restraint or any restrictive interventions. Those are to be used as very, very last resort in the hospital. And in fact, at Eastern State, for example, we have a robust review process for any time that we have to use any restrictive intervention. Our entire leadership team gets together to review that. And we ask the staff questions and we make sure that that was absolutely was there anything else we could have done before that to ensure the safety of that individual? But least restrictive environment also means access to the community. And so hospitalization is a locked facility. It means that you are in a contained environment for your safety, but that should be used only to the least extent possible. We want people to access their community when they're safe to do so. Um, there's also a lot of rights around being involved in your treatment and having informed consent around treatment. So just like any other medical setting, patients have a right to be informed about their care, to ask questions about their care, to understand the risks and benefits and their options for treatment. So we do our best to give options that, this medication might work for you or this medication might work for you. Here's the benefits and the risks associated with those medications, and take that patient's perspective and the family's perspective to the extent that we can in that treatment course. Patients also have the right to refuse treatment. Now, this gets into a gray area because it becomes a safety concern potentially, or requiring long-term hospitalization, but a patient has the ability to decline and say, I don't want to take that particular medication. It didn't work for me before, or I had a family member who had a really bad reaction to that. And it's our obligation as an inpatient setting to work with that individual and say, here are the other options, and to go through those treatment options with them. Confidentiality and privacy are big components of patient rights as well. They obviously have the right to have their information, their medical information, their psychiatric and substance use information protected. We do not release that information unless we have permission from them to do so. We protect their privacy, even in small ways. In the hospital, the hospital units have large open areas kind of in the middle for the milieu and for folks to interact with each other. But when we're talking with patients, we try to pull them to the side. So we're not asking them personal and private questions in an open setting like that. So making sure we're being aware of confidentiality and privacy. And mental health and substance use treatment actually falls behind an additional layer of privacy needs as well. Another really important right that patients have is the ability to communicate with their support system. So that includes mail, it includes phone, and it includes visitors in the hospital. So we do, as long as it's safe, have visitation in the hospital. We have it nearly every day now. But as long as the patients are safe to interact with their family members, the family member can bring them food, for example. The family member can visit with them and talk also with maybe a NAMI peer support specialist who has lived experience and can share things like NAMI family to family groups and resources for the family member as well. And then with all of these things, we also are required and want to have this process in place where a patient can file a grievance if they feel like their rights are being violated or they're not in a safe environment. They have a right to file a grievance, and every hospital has a process around that. The family members can also file a complaint if they have a concern about the care. Those complaints can go to that organization specifically, or it can go to the Office of the Inspector General in the state. It can go to Joint Commission or Center for Medicaid and Medicare, CMS. And so anytime there's a complaint that's made, we take that seriously, and we have processes in place that compel us to review that and respond to that. So we have to then say something back to that person. We reviewed this. Here's our findings. Help us understand what happened. How can we better serve you? And a patient can file a grievance when they're in the hospital or after their hospital stay. And then, we're going to talk about this as well, but the family has a right to provide information to the treatment team. They can share their experience. They can share their observations of what's been going on with that particular individual. While we as a treatment provider may not be able to share anything back, and that's often a point of frustration with family members as they say, I want to know what's going on with this person. I did the petition, for example. Can I not know what's going on? And there are certainly some limitations into what we can provide to them as far as medical information and treatment related information, but we can always take information from the family and hear their perspective. Um, I think those are the biggest ones, Hannah.
Great, thank you. It's really helpful to hear your perspective as a treatment provider. Judge Tackett, do you have anything you'd like to add?
Just you don't lose your constitutional rights, of course, when you're admitted to the hospital. So we
Mhm.
touched on it, but they've got due process rights to, we talked about the proceedings, the right to notice to be heard, and then to confront and challenge the involuntary admission. So all those due process rights, the rights of confrontation are there. And then the right to counsel, of course, they're going to be appointed an attorney to represent them through the proceedings. So they have the right to have an attorney, of course. They have the right to judicial review. They can't be involuntarily hospitalized forever. So, we talked about the 60 and 360-day limits, and they're subject to review by a court to determine whether further hospitalization is required. And then I think they have a right to also, Dr. Jazinski can correct me if I'm wrong, but to, participate in the plan, to
Yeah.
so and if she didn't say it already, but I think that they get to be active participants. So those are the ones that I'm thinking of.
Yeah, that's a great point, Judge Tackett. And they have a right to testify on their own behalf in court as well. So um hospitals do this differently, but in our setting, we hold court in our hospital once every week on Tuesdays, and we bring the patients down who are on the docket. We offer them the opportunity to come to court to hear the process, but also to testify on their own behalf if they choose to do so.
Thank you both. We have a couple of questions in the chat, but before we get to those, I know Dr. Jasinski, you had talked about some steps that patients can take if they feel that their rights are violated. Can you all expand on that a little bit more and let us know too how patients are informed of their rights?
Yeah, so at the first moment that folks walk into the hospital, we have lots of information posted, and then we talk with patients on admission about their rights. Now, when folks come into Eastern State Hospital, again, it differs a little bit depending on the hospital that you're going into and the process, but patients are informed of their rights as they come into the building, and we know that they are going to be held longer or hospitalized. And those are done both verbally, we provide that information to them. Folks sometimes are not in a place, if you're in crisis, you're probably not processing a lot of information, and we understand that. And so this is also in a written format. It's provided in a patient handbook in a sort of digestible way to them. And in there, it also talks about the grievance process. So if you have a concern about your treatment, here's how to get a form to fill out. Here's who to talk to, which in our hospital, it's the active treatment coordinator, the person that's assigned to oversee all of their treatment. And then they are provided with a writing instrument and the ability to submit that grievance form. The information about patient rights is also in the hospital posted throughout the hospital so that they have the ability, if they're moving about the unit, to look at it as well. So, and we provide it at any point in time that they have questions. Many times patients will ask, about their rights and their due process and the court process and all of that. And we provide that information. Typically, it's their treatment coordinator that's answering those questions. That treatment coordinator is a social worker, so also can serve as sort of their case management contact.
Great, thank you. Judge Tackett, do you have anything you'd like to add? No? All right. Let's touch on these questions in the chat. The first, what places hold people for 360 days for substance abuse treatment, or is that more IOP outpatient?
I am not a treatment provider, but I know that there are facilities that will do up to 6 months for sure. With step down programming, it's conceivable that they may go longer than that. Casey's law as well. I mean, and I guess that's probably where the context is. You're looking for satisfaction of goals. For us, just as a comparison, our mental health court is a year long because we think it's going to take a year for you to develop that wellness plan and to be really solid in it before we feel good about you moving on and graduating. So, can someone, do they need 6 months or more inpatient treatment? Probably not everybody, probably very rare. So you're looking probably that they've qualified, that they've gained some sobriety there. They've, good track record. And then they're probably stepping down into, IOP, sober living, those sorts of step downs. So I don't know for sure because I'm not a treatment provider. It sounds like there probably is a facility out there to keep you a year, but it's probably very rare that you would need a whole year in a facility such as that.
Thank you. Dr. Jasinski, do you have anything you'd like to add?
I agree with that. I think that's a full continuum of care. And much like other spaces, remember that it can be up to, and that's an important component of this, that somebody may certainly look different after 6 months of treatment, and that might have only been 30 days of inpatient substance use treatment, for example. Also keep in mind that a driver of this is payer and sort of meeting that level of care through ASAM criteria and things like that for that level of care. But there's always partial hospitalization and intensive outpatient programs that can then step down. So you're going maybe 4 hours a day and then moving down to outpatient treatment a couple of times a week.
Thank you. Another question is about 202B, asking if that has the same 60-360-day review process.
So 202B, yes, as it's written, 202B functions a little bit differently in the community than 202A, but they are written very similarly. So just for context, for those who may not be familiar, 202A is for involuntary hospitalization for individuals with primary mental illness. 202B is for individuals with developmental and intellectual disabilities. And that process functionally looks different in the community. So folks on a 202A, there may be a family member that would petition and they would come directly to the hospital once the judge has signed off on that order. Typically, while you can do a 202B petition in the community, typically that person is residing in some sort of either residential or hospital setting that is going to require specialized care through the 202B process. So it looks a little bit different functionally, but has the same type of review process and certification process. So there's always a professional, a clinical professional testifying that that individual meets that level of care. And then there's a judge who is going to render an opinion as to do they believe that person does meet that need under the statute for involuntary treatment under 202B.
Wonderful. Thank you. Judge Tackett, any additions? No. Well, oh, go ahead. This next question will bring us back to the conversation about confidentiality and rights. Someone asked if consent and rights are an ongoing process as patients may progress in their capacity to understand.
Yeah, absolutely. It has to be, right? By nature of the brain being impacted by mental illness, it certainly is an iterative process, and we are revisiting that. One thing I didn't mention in terms of voluntary treatment in the hospital, and this is a good example that goes into this, is let's say that someone comes into the hospital and they are on a 72-hour hold. At every single day, we are talking to that person about actually removing that hold and having them sign into the hospital voluntarily to engage them in treatment. It is never our goal to hold someone involuntarily. It is always our goal for them to participate in treatment, for them to understand their rights, and to consent to everything that's happening. So that is certainly an ongoing process. In the inpatient setting, our teams are meeting with patients every single day and reviewing these processes, making sure we're doing the least restrictive thing, but the most helpful thing for the patient.
Great, thank you so much. We have just under 10 minutes left, And Judge Tackett, did you have something you wanted to say?
Well, this is something that I think I've sort of picked up by doing this job for 7 or 8 years, but I've heard say that, involuntary commitment is not the best pathway to starting a wellness routine. You're compelling someone to, and that's something for families to kind of have to wrap their minds around. You're really looking for when that person is willing. And we see that that's probably from where I have people admitted into my mental health court is, is this person, are they at a stage where they're willing to change their life? Are they willing to do the hard work of recovery? And so that's the thing that our team grapples with a lot with our folks that we really want to help, but we just don't see that they're probably there. And so we're making a determination that, if they're not willing, they'll probably have to go back to criminal court and face the music. You know what I mean? So I guess that's a big thing that I've learned is, 202A is not gonna, in a lot of instances, bridge that willingness gap to get them to where the family probably wants them to be.
Thank you. We've got 7 minutes, and I want to make sure that we have an opportunity to talk about alternatives to inpatient care. But before we move on from rights, I know you both have mentioned family involvement. What rights do families have to receive information, participate in treatment planning, raise concerns, and then also how can clinicians balance patient confidentiality with family involvement, especially in crisis situations?
Yeah, I'll touch on this really briefly. Families have rights to access information about their loved one to the extent that the loved one is willing for us to be able to provide that information to them. Like I said, the family can always provide information to the treatment provider, but we do have to be dependent upon the individual. And much like I talked about with consent and moving someone to voluntary treatment, we revisit the are you willing to allow us to talk to your support system conversation nearly daily in the course of an inpatient setting? And so while they might be angry if they've been involuntarily petitioned to the hospital by a family member, we eventually usually can get there where they're allowing us, they will sign a release of information and that release dictates sort of the type of information we can share. But we typically can get there through the course of treatment where the family can be engaged. And once we have that release, then the family can help, participate in treatment related meetings, in discussions about outpatient planning, in providing feedback on whether they think the plan is going to be sufficient or whether that has been effective in the past or not been effective in the past. So we prefer as much as we can to have that support system involved.
Thank you. All right, let's move on to talk about the changing landscape and alternatives to inpatient care. And Dr. Jasinski, I'm hoping you'll tell us a little bit about the empath unit. But
Or
what alternatives to inpatient treatment are becoming more available or effective? And then also, what barriers still exist to accessing those alternatives, particularly in rural communities, like the transportation barrier that you mentioned earlier, Judge Tackett?
Yeah, I'll talk briefly and then Judge Tackett can chime in as well. We've done a lot in Kentucky. Kudos to our DBHDID colleagues. There's been a lot of work in Kentucky and through the Kentucky Judicial Commission and all of our advocacy groups to really change the landscape of how we provide care and access to care. So traditionally there have been, and there's still lots of different crisis stabilization units. The growth more recently has been on the Empath unit implementation at UK. And Empath is designed to be very, to fill gaps in our system. So what we know is, with 202A criteria, those criteria can be pretty stringent to get into the inpatient setting involuntarily. But the ED is also not the place to do this work. Crisis stabilization units tend to be for that lower level of crisis at times. But empath units are extremely low barrier and can take care of anyone from low level, sort of overwhelm, anxiety, depression, crisis, all the way through to substance use, comorbid conditions. And we have it at UK's Empath, we've seen 8,300 patients in 19 months of operation. And it's been just a really awesome model. The state then put forward a proposal for rural health transformation dollars, and empath and mobile crisis are part of that continuum. And we'll be continuing to grow with those. We anticipate 4 more empath units in the state of Kentucky over the next several years with those funds, as well as expansion in telebehavioral health and mobile crisis. The continuum with paramedicine teams being trained in the field through mobile crisis teams who are available to support individuals, and then moving into empath, which is where to go. That's not the emergency department, has been a really awesome sort of transition in the state over the past several years. So I think that's going to continue to grow.
Empath has been amazing and a game changer for us in Fayette County and the surrounding counties. So it's just been a wondrous thing because we see so fewer involuntary commitment petitions here at the courthouse due to their good work. I list them real quick, but I echo everything Dr. Chizisky says. 988, it's a wonderful resource. ACT Team, which is out there providing sort of hospitalization programming for folks who are in community. The telehealth, since COVID, that's been a huge help, especially in rural communities, that if we can get, someone speaking to a psychiatrist out there. We already talked about AOT courts, keeping people medication compliant. I'll throw out, a big uh, props to my mental health court and keeping people out of jail by doing, mental health. And then we have a really wonderful paramedicine team here in Fayette County, and they're just amazing. So hopefully that's spreading across the state to those sorts of groups with police and paramedicine together to try to respond to crisis, keep people out of the hospital.
It's so exciting to hear about these steps forward, and shout out to all the people doing the amazing work, you two included. We have 1 minute left, so if you all, we have another question in the chat as well. Any major changes with House Bill 485?
I know
We could probably talk a whole nother
yeah,
hour.
it's another
Yeah.
hour. It just passed the Senate, but I could just say that our Judicial Association and Dr. Justice, we did not like it at the very beginning, and
Yeah,
it's turning into a much better piece of legislation by the end. So I'll just say that if that's okay.
agreed. And we really shifted the initial sort of written language was around having most of the decisions made by the judiciary about care, and it's moved back to the clinicians, which is sort of our preference. But there is a really nice focus on AOT and utilization of outpatient resources to keep people out of the hospital. So I think it's in a much better place. I do think that in general, we've seen a shift back towards inpatient care a bit more. Many of you might know, Eastern State Hospital census 2 years ago was about 145 patients, and our census today for this fiscal year is 175 patients. So it's certainly grown in the inpatient space and the need.
And thank you, Dr. Jasinski and Dr. Sheila Schuster and everyone else who worked on House Bill 485. Do you all have 1 more minute to answer one last final question?
Sure.
Yes. Okay. I'd love to hear just from each of you one key takeaway that you want participants to leave with about navigating inpatient psychiatric care, and maybe one resource as well that folks can turn to after this webinar for support or information.
All right, Judge Tackett, you want to go?
Okay. This is a wonderful resource again. Find it. I think my big takeaway, especially if you're a family member, I mean, a lot of folks here, I see that, you all are in the business, but if you're a family member or friend with someone with serious mental illness, just don't be afraid to ask for help. Because I mean, these are processes that are confusing to the professionals, and a lot of times what we've done deep dive is one hand doesn't know what the other hand's doing a lot of times. So that's what's wonderful about the Judicial Commission on mental health. We're really judges can convene, and that's what we're doing. We're putting all the stakeholders at the same table to find out what's going on because what's working maybe, great in the courthouse here might not be working, worth anything out in community, and so we need to hear that information. So that's what the commission's been so wonderful and instrumental in the last 3 or 4 years it's been around. One entity, I know you got NAMI Lex, you got the mental health of Alliance of Kentucky. One entity that you may not be thinking of, which is a great point, is the county attorney's office because they're dealing with folks with mental illness. They're filing guardianship petitions. They're the ones prosecuting these things. So that might not be your first thought as to getting help, but you can talk to you know the county attorney's office, and there's usually a designated prosecutor that deals just with mental illness from your county attorney's office. So that's what I have to say.
Thank you. Dr. Jasinski?
I was actually going to say something similar. When in doubt, calling your local county attorney's office can be really helpful. They can guide you through those steps. But what I would add to that is one, I hope what you take away from this is that our system is growing and changing and evolving in really positive ways. And Kentucky, believe it or not, is very advanced and progressive in behavioral health across our state. We have a lot of work to do, but we also have more resources than a lot of communities in a lot of other states. Um, I, I would also just add to what Judge Tackett said by saying, have a plan for who you would call and how to get in touch with someone. What are your local resources before you ever need it? You're much better off to have thought this through. What would I do if my child or my mother or my neighbor presented to me suddenly one day with a mental health crisis? Because we never know when it can be any one of us, any one of our loved ones. And so spend a little time, it could be 10 minutes, thinking through what would I do to who would I call? Where would I get help? So that when you're in the heat of that moment and something comes up, it's much harder to think clearly. And so it's important for all of us with our loved ones just to have a plan and have a thought of how you can do this.
Absolutely. Dr. Jasinski, Judge Tackett, thank you both so much for your expertise and your time. Thank you, everyone, for joining us today and staying on a few extra minutes. This webinar recording will be uploaded to YouTube, so you all can watch it after and review again if needed. But again, we're so grateful to both of you and wishing everyone a wonderful weekend.
Most welcome.
Take care.
Thank you.
Thank you.